Good afternoon, and thank you for the opportunity to present my Doctor of Nursing Practice Scholarly project. My name is Kimberly Wingard, and my project is titled Implementing Trauma-Informed Care with Cognitive Processing Therapy to Improve Treatment Engagement among women ages 18 to 55 years with substance use disorders and high adverse childhood experience scores. This is a quality improvement project. This project represents the culmination of my doctoral education and reflects the translation of current evidence into clinical practice. Today I will discuss the practice problem, supporting evidence, implementation process, the project outcomes and implications for practice, and the leadership role of the Doctor of Nursing Practice, prepared nurse, in leading evidence-based quality improvement. Childhood trauma is one of the strongest predictors of substance use disorders among women, yet trauma frequently remains under-recognized and undertreated in behavioral health settings. Before I begin, I would like to acknowledge my committee members for their guidance and support throughout this project. I would like to thank my committee chair, Dr. Maria Snell, and my previous chair, Dr. Angela Atkinson, for their mentorship and expertise in quality improvement methodology. I also appreciate Dr. Sarisa Moore for her thoughtful feedback, which has strengthened the scholarly quality of this project. Finally, I would like to thank my community member, Dr. Demetrius Green, for supporting the implementation at the practicum site and providing valuable clinical insight. I am sincerely grateful for their encouragement throughout this doctoral journey. Background. To understand why this project was needed, it is important to recognize the relationship between childhood trauma and substance use disorders among women. Research demonstrates that women with substance use disorders have significantly higher adverse childhood experiences, or ACE, scores than women without substance use disorders. In addition, between 70 and 90% of women receiving treatment for substance use disorder report a lifetime history of trauma. These trauma histories contribute to PTSD symptoms, treatment disengagement, and relapse. Women with elevated ACE scores often experience greater difficulty engaging in care, remaining in treatment, and achieving long-term recovery. These findings highlight the importance of addressing both trauma and substance use at the same time through evidence-based interventions. Although trauma-informed care is widely recommended, many addiction treatment programs continue to focus primarily on substance use while giving less attention to underlying trauma. According to SAMHSA, trauma-informed care recognizes the widespread impact of trauma and emphasizes physical and emotional safety, trust, collaboration, empowerment, and cultural responsiveness. Implementing these principles help reduce the risk of re-traumatization while creating an environment that supports engagement and recovery. These concepts provided the clinical foundation for this quality improvement project. The practice problem at the practicum site involved inconsistent treatment, engagement among women with substance use disorders who also had significant childhood trauma. Each additional adverse childhood experience increases the likelihood of substance use disorders, while women with extensive trauma histories are more likely to experience, as mentioned, PTSD, depression, anxiety, and early treatment dropout. These challenges negatively affect both patient outcomes and continuity of care, reinforcing the need for a more consistent approach to trauma treatment. The practice gap. The gap was not that trauma was ignored, rather trauma-informed care was delivered inconsistently. Clinicians discussed trauma during treatment, however, intervention delivery varied across providers, and structured cognitive processing therapy principles were not consistently incorporated into routine practice. As a result, evidence-based trauma care depended largely on individual clinician preference instead of a standardized protocol. This inconsistency provided the rationale for implementing standardized trauma-informed care protocol across the clinic. The purpose and clinical question. The purpose of this quality improvement project was to determine whether implementing a standardized trauma-informed care protocol incorporating cognitive processing therapy principles would improve treatment engagement and reduce PTSD symptom severity among women between the ages of 18 and 55 with substance use disorders and an ACE score of 4 or greater over a 10-week implementation period. The primary outcome included treatment engagement, PTSD symptom severity measured using the PCL-5, and clinician adherence to the standardized protocol. The aim of this project was straightforward: to implement and evaluate a standardized trauma-informed care protocol incorporating cognitive processing therapy principles within an outpatient behavioral health clinic. Rather than developing a new therapy, this project focused on improving the consistency with which evidence-based trauma care was delivered, while evaluating its impact on patient engagement, trauma-related symptoms, and implementation fidelity. The literature review. Current literature consistently supports trauma-informed care as an effective strategy for improving treatment engagement, therapeutic relationships, and retention. Cognitive processing therapy remains one of the most effective evidence-based psychotherapies for PTSD and has demonstrated positive outcomes among women with co-occurring trauma and substance use disorders. Implementation science further emphasizes that successful practice changes require more than selecting an effective intervention. Standardized clinician education, organizational support, fidelity monitoring, and continuous quality improvement are essential for achieving sustained implementation. Collectively, the literature demonstrates that trauma-informed care and cognitive processing therapy provide a strong evidence base for improving trauma-related outcomes. Equally as important, implementation science shows that standardized protocols, clinician education, and fidelity monitoring are necessary to successfully translate evidence into routine clinical practice. These findings directly informed the design of this quality improvement project and provided the rationale for selecting a standardized trauma-informed care protocol as the intervention. Having established the evidence supporting the project, I will now describe the framework and the methodology used to implement the practice change. Theoretical framework. The Plan, Do, Study, Act, or PDSA framework guided this quality improvement project because it provides a structured process for implementing, evaluating, and sustaining practice change. During the plan phase, the practice gap was identified, the literature was reviewed, and the standardized trauma-informed care protocol was developed. The Do phase focused on clinician education and implementation of the intervention. The study phase involved monitoring treatment engagement, PTSD symptom severity, and clinician adherence, while the ACT phase used project findings to develop recommendations for sustaining the practice change. Overall, the PDSA framework ensured that implementation remained systematic, measurable, and focused on continuous quality improvement. The project design. This project used a quantitative pre- and post-implementation quality improvement design guided by PDSA framework. Baseline data were collected retrospectively through chart review followed by a 10-week implementation period. The project was conducted in an outpatient behavioral health clinic providing integrated mental health and substance use treatment. This methodology allowed evaluation of a practice change within routine clinical care implementation framework. This framework shows the progression of the project from identifying the practice gap through sustaining the intervention. The process begins with recognizing inconsistent trauma-informed care, followed by reviewing the evidence and planning the intervention using the PDSA framework. Clinicians then completed standardized education before the protocol was integrated into routine outpatient care. The outcomes were evaluated through implementation, and the findings informed recommendations for sustainability through ongoing quality improvement. The final sample included 35 women between 18 and 55 who met the inclusion criteria. All participants had an ACE score of 4 or greater and a DSM-5 diagnosis of substance use disorder. The sample represented a diverse patient population, with alcohol use disorder being the most common diagnosis. Importantly, all participants completed the 10-week implementation period, resulting in complete outcome data for analysis. Implementation fidelity was a major focus of this project. Before implementation, clinicians completed standardized education in trauma-informed care and cognitive process and therapy principles. Eligible patients completed ACE screenings and baseline PCL5 assessments. Trauma-informed, CPT-informed interventions were then delivered as part of routine clinical care. Weekly documentation audits and fidelity monitoring ensured consistent implementation throughout the project, while ongoing PDSA evaluation supported continuous improvement. The implementation occurred over 5 phases. Phase 1 established baseline performance measures through retrospective chart review. Phase 2 focused on clinician education and protocol standardization. During Phase 3, the standardized trauma-informed care protocol was implemented into routine practice. During Phase 4, there was an emphasis on weekly quality assurance through fidelity monitoring and documentation audits. Phase 5 focused on outcome evaluation, data analysis, and dissemination of project findings. Throughout implementation, clinician adherence steadily improved while the protocol itself remained unchanged, ensuring consistency of intervention delivery. Implementation activities and outcome measures. The primary outcome measure included treatment engagement, PTSD symptom severity using the PCL5, and treatment completion. Secondary outcomes included clinician adherence to the standardized protocol and implementation fidelity. In addition to these outcomes, contextual factors such as clinician participation, workflow integration, documentation consistency, and organizational support were considered when interpreting the results. Together, these measures evaluated both patient outcomes and successful implementation of the practice change. Data analysis. IBM SPSS Statistics version 29 was used for all analysis. Descriptive statistics summarize demographic characteristics and implementation outcomes. Because PCL5 scores were continuous data collected before and after implementation, a paired sample t-test was selected to compare changes in PTSD symptom severity. The Shapiro-Wilks test confirmed that the normality assumption was met, supporting the use of parametric analysis. Effect size was also calculated to evaluate the clinical significance of the observed changes. With the methodology complete, the next section presents the project findings. Baseline findings confirmed that the patient population had substantial trauma-related needs. All 35 women had an ACE score of 4 or greater and clinically significant PTSD symptoms at baseline. Treatment engagement before implementation was only 60%, and clinician adherence to trauma-informed care practices was 70%, demonstrating variability in how trauma-focused interventions were delivered. Following implementation of the standardized trauma-informed care protocol, meaningful improvements were observed in every primary outcome. Treatment engagement increased, PTSD symptom severity decreased, and clinician adherence improved. Collectively, these findings suggest that implementing a standardized trauma-informed care protocol incorporating cognitive processing therapy principles was associated with meaningful improvements in both patient outcomes and consistency of care. Further results, clinical and process outcomes. Looking more closely at the clinical and implementation outcomes, treatment engagement increased from 60% at baseline to 91% following implementation, representing a 31 percentage point improvement. This increase is clinically meaningful because improved attendance allows patients to receive treatment more consistently and supports continuity of care. Clinician adherence also increased from 70% to 95% over the implementation period. Rather than occurring immediately, adherence improved progressively as clinicians became more comfortable applying the standardized protocol. These findings demonstrate successful implementation of the practice change and highlight the importance of standardized education, ongoing feedback, and fidelity monitoring in supporting evidence-based practice. PTSD symptom severity was measured using the PTSD checklist for DSM-5 or PCL-5. Mean scores decreased from 50.37 at baseline to 35.54 following implementation, representing a reduction of 14.83 points. This exceeds the established threshold for clinically meaningful improvement on the PCL-5. Statistical analysis confirmed that the reduction was significant, indicating that improvements were unlikely due to chance. When considered alongside the increased attendance and improved clinician adherence, these findings suggest that the standardized trauma-informed care protocol was associated with meaningful improvement in trauma-related symptoms among women with substance use disorders and high ACE scores. This discussion focuses on what these findings mean rather than simply reporting the numbers. First, treatment engagement improved after implementation of a standardized trauma-informed care protocol, suggesting that consistent trauma-informed communication and structured cognitive processing therapy principles supported greater participation in care. Second, reductions in PTSD symptom severity are consistent with published evidence supporting cognitive processing therapy for individuals with co-occurring trauma and substance use disorders. Finally, the steady improvement in clinician adherence reinforces implementation science, principles demonstrating that standardized education, implementation fidelity, and continuous quality improvement are essential for successful practice change. Overall, these findings support the feasibility of implementing standardized trauma-informed care within routine outpatient behavioral health practice. Several limitations should be considered when interpreting these findings. This was a single-site quality improvement project involving a relatively small sample and a 10-week implementation period, which limits generalizability and does not allow evaluation of long-term sustainability. In addition, the absence of a control group and the use of a retrospective baseline data prevent attributing the observed improvements solely to the intervention. However, several strengths helped mitigate these limitations. Standardized implementation procedures, prospective outcome monitoring, validated outcome measures, and routine fidelity audits strengthen implementation consistently and data quality. Because this was a quality improvement project, the primary goal was to improve local clinical practice rather than establish causality. These findings provide a strong foundation for future projects involving larger samples, multiple sites, and longer follow-up periods. This concludes the results section, and I will now discuss the sustainability of this project. Sustaining the practice change requires continued organizational commitment beyond the implementation period. Recommended strategies include ongoing clinician education and competency development, routine fidelity monitoring, documentation audit, leadership support, periodic review of outcome data, and continued use of the PDSA cycles. Although long-term sustainability was not evaluated during this 10-week project, these strategies provide a practical framework for maintaining implementation fidelity and supporting continuous quality improvement. This project has implications at several levels. For patients, the standardized protocol was associated with improved treatment engagement, reduced PTSD symptom severity, and a more trauma-informed therapeutic environment. For providers, standardized education promotes more consistent delivery of evidence-based trauma care and strengthened interdisciplinary collaboration. Organizationally, the project established standardized workflows and implementation processes that can support future quality improvement efforts. Overall, these findings demonstrate how structured implementation can improve both patient outcomes and consistency of care. This project also shows the unique leadership role of the Doctor of Nursing practice, prepared nurse. Throughout implementation, I translated current evidence into practice, led an interdisciplinary quality improvement initiative, used outcome data to evaluate effectiveness, and collaborated with organizational stakeholders to support implementation. These are core competencies of DNP practice and demonstrate how advanced practice nurses lead meaningful change within complex healthcare systems. This quality improvement project successfully translated current evidence into a standardized trauma-informed care protocol and practice change within an outpatient behavioral health setting. Beyond improving clinical outcomes, the project demonstrated that evidence-based practice can be implemented using a structured approach supported by the clinician education and implementation fidelity and continuous quality improvement. Although future initiatives should evaluate long-term sustainability and broader implementation, this project provides a practical framework that other behavioral health organizations can adopt when implementing trauma-informed care. Ultimately, this project demonstrated that implementing a standardized trauma-informed care protocol is a feasible and practical quality improvement strategy associated with improved treatment engagement, reduced PTSD severity, and greater clinician adherence. More importantly, it highlights the role of the doctor of nursing practice, prepared nurse, in translating evidence into sustainable, patient-centered practice change that improves the quality of behavioral health care. As I conclude, I would like to briefly reflect on what this journey has meant to me. Throughout my Doctor of Nursing Practice education, I gained a much deeper appreciation for implementation science, for leadership, and evidence-based practice. I learned that meaningful practice change requires more than identifying the best available evidence. It requires collaboration, thoughtful planning, continuous evaluation, and the willingness to adapt within real-world clinical setting. This experience strengthened my confidence as a psychiatric nurse practitioner, reinforced my commitment to trauma-informed behavioral health care, and affirmed the important role of DNP prepared nurse in leading quality improvement that improves patient outcomes. Thank you for your time and attention, and this concludes my DNP project.